Welcome, everyone, and thanks. Welcome to Science Says. My name is Tom Lynch. I'm the president and director of the Fred Hutch, and I could not be happier to be with all of you this afternoon, or late in the afternoon if you're in other parts of the country. Today, or not today, but on Friday, will mark the 1-year anniversary of the merger between the SCCA and the Fred Hutch Cancer Research Center to form the Fred Hutch Cancer Center, who, along with University of Washington, is working very hard to redefine cancer care and offer more cures to patients with cancer. So we are, again, very proud to be joining UW and being able to talk with you today about advances in cancer. I want to take a moment to thank our presenting sponsor, which is Microsoft. The impact that Microsoft and Microsoft employees have had in Washington is really incredible. In 2022, Fred Hutch was among the top 5 organizations that were supported locally by Microsoft employees and the Microsoft Employee Giving Program. And we're so grateful for all the work that Microsoft employees do to help support the Hutch and to enable our mission. Many do support the Hutch through Obliteride, and just to remind everyone in this call, I want to see everyone who's here participating in Obliteride in some fashion. It will be August 12th. This will be the first year that we will have disease-oriented teams. So we'll have a breast cancer team and a prostate cancer team. And if you want to raise money for breast or prostate or colon or lymphoma or leukemia or transplant, you can do that. And we're very excited about being able to do that to empower patients and their families at the Fred Hutch to be able to participate. So again, really looking forward to Obliteride on August 12th. Registration will open next week. So today we're talking about innovation. And we're going to talk about care innovation. And much of the work we've done has talked about science, and it's called Science Says. And we've talked about how new science approaches enable remarkable new things that we can do for patients. But today we're going to talk about how new structures of care can actually advance the way we care for patients. And we're going to talk about the most recent example of this commitment to bringing research and care closer together for patients, particularly patients who've got solid tumors. And what do I mean by solid tumors? By solid tumors, I mean breast, lung, colon, pancreas, ovarian, as opposed to leukemia, lymphoma, transplant, which are incredibly important tumors as well. But today we're going to focus a little more on solid tumors. Now, yesterday, we opened the doors on a brand new 150,000 square foot clinic building on our South Lake Union campus. And here you see a picture of the ribbon cutting to open this, and you see Terry McDonald with the appropriately branded blue blazer, which is the perfect color for the Fred Hutch. And you see that our patient advocate is about to use the scissors to open and build a new building. And we're joined there with Kathy Sarah Smith, our board chair, and Nancy Davidson, the head of clinical, and Fred Applebaum is there as well, who had been the head of the SCCA before Nancy. So really a terrific day in history of the Fred Hutch. And opening the facility yesterday was even more important. This state-of-the-art expansion is a result of years of thoughtful planning with Fred and Nancy and Terry and Steve and other patient advocates, nursing advocates, who worked hard to really rethink what are the things that patients need? What are the things that families need when they're being cared for? And there were several key design principles that drove this process. First, we wanted to build on our foundation of innovative science, in part by expanding our imaging capabilities to be able to detect solid tumors and to make a detailed diagnosis and to be able to tailor treatment plans. Second, we wanted to accelerate our precision oncology efforts. As you know, Stuart Sloan and Molly Nordstrom gave a significant gift to the Fred Hutch last year to establish the Sloan Center for Precision Oncology. Can't wait to start groundbreaking on that and to be able to build our precision oncology building as we move forward. And this will fuel our search for better treatments for patients in the future. And above all else, we endeavored to set a new standard for compassionate and connected care for patients and families. And I think that's something really, really important. So today we've gathered a panel of clinicians, researchers, and staff who will be leading this effort and who are going to tell us about what they've done to make the new Fred Hutch work even better. So let's meet our first speaker. Our first speaker is Dr. Terry McDonald. Terry is our Chief Nursing Officer and a practicing acute care nurse practitioner. I have had the pleasure of working with Terry for more than 34 plus years. We both worked together back in Boston generations ago, when I won't say I had dark hair, but it was less gray than it is now. Terry's been a pivotal member of the team at the SCCA and now the Fred Hutch, who designed the clinic spaces of the new building and brought a unique perspective to how we can care for patients better. Terry's also an exceptional clinician herself, and that informed, I think, a lot of the decision making that's used. Terry, welcome. It's fantastic to have you here today.
Thank you, Tom.
So Terry, first question: when you decide you had a blank slate, and you've been in cancer nursing for a long time, and you've seen what works, what doesn't work. What were the elements of the patient experience that you used to drive the guiding principles of our new building?
That's a great question. And in fact, Tom, I'm coming to you today from the care neighborhood. I just finished my clinic this morning. When we thought about designing this new space, we wanted to make sure that we had the patient and family voice and the provider voice and staff prominently at the center. And we had a design team of over 50 people, and we sat down and we basically threw a bunch of ideas on the table, things that we wanted to fix in this new environment. Time wasted for patients and families. Wait times, movement, multiple check-ins, stress in even something like parking, coming to the facility. We wanted to really make an environment that, while coming to a cancer center is difficult at baseline, we wanted to make it as easy as possible on our patients and our families. So we wanted it to be open, welcoming, a less institutional feel, and we wanted everything to come to the patients and the families and not have their time be sitting idle while waiting to check into multiple locations and multiple appointments. So those were a lot of the things we sought to fix when we designed it.
Well, Terry, if you think back to when you and I practiced 30 years ago at MGH, a patient would walk in to the hospital, they would get their bloods done, they'd then go to the waiting room. They would then get put in a room and they would then wait to see me. I would then see them, I would write their chemotherapy orders, and they would go to a waiting room and they would check in at a second place and then wait to be brought back to the infusion chair. And they'd be brought back to the infusion chair, then they'd wait to see their oncology nurse practitioner or their oncology nurse. So there were multiple steps. How is a care neighborhood different than that? Because those are all still important parts of how we care for patients, but the patient wasn't at the center of what we're doing.
So now, patient comes, they go up to their care neighborhood floor, they check in, and they're brought to a universal room. And that's their room for the day. And everything is dynamic. So I'm there next to Gabi or Veena Shankar and one of our other providers, other APPs, nursing, and the MAs, and everything comes together. So the nurse goes in, does the assessment, draws the labs, we touch base, I go in, make my evaluation. If I've got questions for the attending, I can turn, the attending's right there. And then I can let the nurse know that the patient's ready for their infusion. Nurse orders the chemotherapy or whatever therapy they're getting. Pharmacy delivers it, and it all comes to the patient. And we've also got a great environment where we can collaborate in real time and we can communicate in real time. And the patient and their family member has access to snacks. They can go to the promenade, walk around. But we're bringing everything that's needed for that patient to the patient. Labs, infusion, all of it.
One of the things I found in touring the new facility is how beautiful and how open the public spaces are, and how the public spaces really do let family members walk around, look outside, get the great view of South Lake Union, And it really does have a very open, spacious feel to it. So I guess one practical question is, we've all known this from our oncology backgrounds. Occasionally, somebody comes in for care and their bloods are not right, and they have to wait a couple days before they can be treated. What happens to that room if it's been reserved for the patient all day, and then you find out when they get here that their bloods aren't right and they have to wait a couple days?
Well, so that patient will go home, and we're constantly getting calls and bringing patients in for evaluation. Maybe they've had a fever, maybe they're dehydrated. So we have the ability to put another patient into that space and flex as the patient demand dictates.
So I can see how the care neighborhoods are great for patients, okay? Because I think a patient and family being in one place would be great. But how about for the providers? What about for the nurses, the doctors, the nurse practitioners? Does it work as well for a provider as it does for the patient?
So that was heavily debated and hotly debated at the beginning because there was a lot of question, were we going to be wasting provider time? And I think what we've discovered is that having everyone in one space makes the day actually go much faster and easier. Rather than a nurse trying to page me, have me call back, wait for the nurse because she's in another patient room, and just, again, a lot of back and forth, a lot of waiting. I can turn around, I can walk over to that nurse, or the nurse can come to me, and we can have a discussion about what's happening. Say that patient's labs don't look good. We're having a real-time discussion on what the next steps are, and then I can walk back and talk to the scheduler and the practice nurse. So it's all right there, and it's all in real time.
So Terry, we got a question. We got a question right now from Roy, and Roy asks, "What solid tumors are being treated in the new facility?"
So right now we are open on the third floor, which is primarily GI, and over the next coming week.
No surprise, that's the tumor that you treat.
Well, also Dr. Curian, and there's many of us. GI is a high volume center.
No, I know.
Thoracic head and neck will be coming over.
Good.
DU will be coming over, and our surgical specialties will also be coming over into the new building.
Terrific. And Terry, how did the first day go yesterday?
The first day exceeded our expectations. We all know that opening anything new comes with glitches and systems issues, and I would say the punch list at the end of the day was much shorter than we anticipated. All in all, it went really well. We treated over 75 patients yesterday.
Wow. And then what about going back and forth from the new building to the existing Fred Hutch? How do people make that transition if they've got to go back there?
So we've got a passageway on the first floor. It's actually a beautiful open bridge that goes from building 2 to building 1. And it just so happens that our brand new gift shop is right there. And yesterday there was a lot of patient celebration around that. It was a great day. Patients really enjoy it. They can go back and forth. They have access to both buildings, parking in both buildings. We've got a smoothie bar here in building 2. It's all covered, all inside, and it's a nice walk for the patients if they choose to make it.
So Terry, that's fantastic. And Lori Dolan, who's on our board of advisors and is listening and participating today, she says, "Thank you. Having gone through 2 stem cell transplants in 2003 and 2008, the old-fashioned way, this new team strategy sounds terrific for both patients and providers." So if I were Lori, I'd be wondering, is this something we're going to be able to do for stem cell patients, leukemia patients, liquid tumor patients?
Oh, absolutely. And this is really the care neighborhood is the culmination of the early building blocks that were set forward in BMT. BMT was the first team-based care model at the Fred Hutch, and we're just going to continue to build and evolve. So yes, absolutely.
And so Terry, I just want to finish by thanking you for your leadership in this area. Your skill and commitment to compassionate healthcare is extraordinary, and I think this new building shows so much of you in it. And I think we're incredibly happy about getting it open. And thanks for all you do for the Fred Hutch and for our patients. And I think we'll see you in a little bit during the Q&A.
Thank you, Tom.
Terrific. So let's now bring on Dr. Delphine Chen. Dr. Chen is a board-certified physician in nuclear medicine and is Fred Hutch's Director of Molecular Imaging. And as we said in the very beginning, expanding our imaging capabilities is another benefit of this new building. And Delphine will be critical in helping us incorporate these new imaging abilities into patient care, from improving our ability to detect tumors to tailoring treatment plans for patients' individual needs. Welcome, Delphine. Great to have you with us today. So I guess the first question is, tell us about all the new imaging modalities you have in the new building.
Yeah, so we're really excited to expand in a couple areas. So first is the MR suite, which includes the first PET MR scanner in the entire Washington state and upper Pacific Northwest. So the PET MR combines two different advanced imaging modalities, positron emission tomography, which gives us molecular information about cancer, and magnetic resonance imaging, which gives us even more detailed information about cell viability. So this will give us great diagnostic imaging capabilities. We also have a new CT angio suite. So that has one of the most advanced CT scanners to identify sites that need to be biopsied, and that should greatly increase our ability to see where tumors or concerning lesions are that need to be biopsied. And so that expanded capability will also help with advancing care and really helping to get diagnoses faster for patients.
And so, Delphine, I know we've had PET CT for several years, which combines a PET scan with a CAT scan, and now we have PET MR. What do you think is the biggest advance of PET MR compared to a PET CT?
Yeah, so PET MR allows us to take advantage of really good soft tissue characterization, meaning anything outside the bone. And that's great for solid tumors, so specifically anything in the abdomen, so GI cancers, liver cancers, prostate cancers, uterine cancers, ovarian cancers. All of those can be imaged really well with PET MR, actually even better than with PET CT, because the MRI allows us to see where the uptake is on the PET, and allows us to be more precise about where the molecular information is in terms of the disease extent. And actually, it will be really good for imaging the marrow too. So separately from those solid tumors, we actually will be able to see some of the heme malignancies better, particularly leukemias and myelomas. Those will probably be easier to image also.
And I think it's one thing to point out to people is that the imaging modalities in the new building can be used for solid tumor and liquid tumor patients. It's not just limited to patients who are going to have their treatment in the new building. They can go to other places, which is great. And so the next question that a lot of people are going to ask is the PET MRI sounds quite expensive. Will this be covered by insurance?
Yeah, that's a great question. So from what I gather, the PET portion of when we do a PET MR, which means it's just like the PET CT without a diagnostic MRI scan, that PET MR, we can get it covered like we get a PET CT. What that enables us to do is choose whether we need the PET CT or PET MR to better stage the cancer, depending on which it is, without necessarily having to worry about coverage issues per se. Now, that is something that we will be working with our, billing and rev cycle group to ensure that we can get these covered. But from what I can tell, PET MRs can be covered by the same indications as for PET CT when we make the strong case that we need to be able to see that site better, and we can see it better with the MR than with the CT.
So Delphine, this next question, please do not take this the wrong way. But I read an article in the New York Times recently about artificial intelligence and how AI is enabling better readings of imaging modalities. And so I guess the question is, how is AI helping radiologists, and will they make radiologists obsolete?
Oh yeah, I know. Radiology has been worried about that for decades. We will all lose our jobs because of AI. I don't think that's going to happen though. Just looking at the tools. So AI has made great progress. We were talking about this last night with some other leaders in the institution. AI is in imaging now. We can use it to characterize lung nodules really well on CT and automate reports of how concerning a lung nodule is. And it greatly reduces the radiologist's time to review the scan. It also increases their accuracy because the AI is going to pick up all sorts of subtle features that, when a person, as our imaging has gotten better, we have more and more images to review. And so AI helps us review all those images faster and more accurately. And so I think AI is just going to continue to be used. It's going to slowly make its way into PET and MRI. Right now, most of it is in CT, but we're looking forward to how much it can help improve our accuracy, improve quantification. So we have a number to attach to what we see, and then we can have an objective measure of response. And I know a lot of our patients, because I speak with them personally, they like tracking it in a table. And that makes sense as a radiologist to me. You'd like to see how those measurements are changing. Yeah. And AI could make that more easily done and more accurate as well.
Terrific. So the next question I'm going to ask you is, I know that you're here today as the head of molecular imaging, but I think of you as the person who really brought theranostics to the Fred Hutch. So let's please tell people, what is theranostics and what does it mean? And tell us a little bit about what you're doing, because the work is incredibly exciting.
Yeah, thank you. Yeah, and we're really excited in nuclear medicine as a field about the explosion of theranostics. So theranostics is a combination of a therapy agent and a diagnostic agent. So we take molecules and put a radioactive isotope on it, and we can switch out that isotope to emit radiation that's good for imaging. So that's what we do in nuclear medicine with PET and general nuclear medicine studies. Or we can take that same molecule that targets the same cancer and now put a therapy isotope, meaning that radiation is delivered to the cancer cell to kill it. And so the really advantage of theranostics is that you have a single molecule that targets cancer. We can both see it and we can both treat the cancer. And so now we can see the sites that we are treating, and we can get a gauge of how well is the drug actually getting to the cancer cell and how well is it likely to respond, and we can follow it better. And so there's been a huge explosion of that, particularly with, we've always done it with radioactive iodine for thyroid cancer. That's been around for decades. But the more recent developments with neuroendocrine tumor and then prostate cancer has really taken off, because we see some patients, relatively small subsets still, but we now see some patients that are almost cured, which we hadn't seen before. And these are patients who were progressing through previous therapies. And now we can deliver target radiation and actually cure some patients and stabilize disease in a lot of other patients that were continuing to progress on multiple prior treatments. So there's a lot of excitement in the field. We're actively working on how we can improve the cure rate and improve the stabilization rate, because some patients will still progress. But I think the impact we're having on controlling cancer is really exciting and really high. And so I think there's going to be a lot of work in this area.
And Delphine, you and I have had the chance to talk about this in the past, but just to give you a chance to share with some people, I think one of the things I'm most impressed with are some of the results we're seeing in prostate cancer. And of course, it is not, curing patients with prostate cancer for sure yet, but it's getting some responses that we didn't expect to see.
Yeah, exactly. And that's why, yes, I should be careful about cure, because we have not cured anyone yet, unfortunately. But yeah, we make some of these tumors go away for quite some time sometimes. So, and that is fueled by a lot of research going into what are the best molecules to target the cancer and what are the best ways to deliver the radioactive isotope. And there's research in the different type of isotopes. Some isotopes might be better for really large, bulky tumors. Other isotopes might be better for smaller tumors that are less than 1 centimeter or 2 centimeters. And so, all of nuclear medicine is really undergoing a renaissance in terms of the amount of research that we can do. And that's one of the exciting things about being at Fred Hutch, because so many investigators here work on how do we target the cancer better. And so now there's an opportunity for us to attach these radioactive labels and see how are we delivering it. We can visually quantify how well we're targeting those cancers now and get a better sense of what the likelihood is that we can actually shrink that tumor.
So Delphine, thanks so much. We'll talk to you in just a second when we do the Q&A. Really enjoyed your comments and everything you do for us here at the Fred Hutch. So
Thanks.
next, I'd like to bring on Dr. Gabby Kiorian. Gabby is a gastrointestinal oncologist. She's the clinical research director of the GI oncology program at the Fred Hutch and at UW Medicine. She's a professor both at Fred Hutch and at UW Medicine. And our GI oncology team is the first to see patients in our new building. And by GI oncology, we mean diseases like esophageal and stomach and pancreas and liver and colon and intestine, rectal. Those are all the GI types of cancers. So Gabby, welcome and thank you for your leadership in this area. So Terry talked about the clinical benefits of having the teams close together in the care neighborhoods. From a doctor's perspective, what do you think the benefits are for impacting our research?
Thank you so much, Tom, for having me. And I cannot tell you how excited we are to have moved into the new building yesterday. The GI oncology team, several of us had the chance to work in a care neighborhood model a little bit for the last year or so. But the new building it's really outstanding. From my standpoint, a care neighborhood and the way our cancer clinic is structured enables people to be together both from the point of view of nursing, providers, MDs, and patients, but also having multiple specialists co-locate in tumor boards, in seeing patients together. We oftentimes hold multidisciplinary tumor boards, including pancreatic, colorectal, where the surgeon, the radiation therapist, the medical oncologist, the genetic counselor, nutritionist, they all join forces together, they meet, and we see patients together to provide a multidisciplinary consultation, again, through the comfort of having a universal space. And I cannot speak highly enough about the benefits of bringing, again, patients and providers together, but also multiple disciplines of providers together and conferring basically a joint recommendation for the patient. In addition to that, we have our research teams that provide the consultation and the consenting to clinical trials. And many of our patients that are participating in clinical research trials are also treated in the care neighborhoods in the same space where, again, the consultations occur. So I cannot speak highly enough about the benefits of being together, both with a patient as well as multiple disciplines together.
And so, Gabby, one of the things people may not know is you and I have gotten to work together a lot as part of the Hutch Executive Leadership Group, and you've been very involved in planning our buildings and thinking about how research can work closely with the clinical care. And I think that's one of the perspectives that you bring better than anyone could imagine, because you've got such deep experience with patients as well as research. So I guess one question I would have is, as you know, my history is taking care of lung cancer patients, and when a patient who's got a certain type of lung cancer, maybe one driven by a mutation, has a progression or the cancer stops responding to the treatment, doing a repeat biopsy is really important. And one of the things we are very proud of in this new building is the 5th floor is designed to enhance our biopsy ability. So as a GI oncologist, tell us a little bit about how important it is to be able to biopsy a liver lesion and find out, is it cancer, is it not cancer? What are the molecular abnormalities that are present there, and how will this impact your work?
Thank you for this question, Tom. The field of GI oncology has really changed in the past 5 years, I would say. We used to basically treat all patients the same, provide chemotherapy. We didn't used to have a lot of targeted therapeutics or immune therapeutics for our patients. But today we have a lot of precision medicine. And what I mean by precision medicine is knowing the individual cancer's genetic aberrations, genetic abnormalities, such that we can tailor the treatment for patients based on the genetic abnormalities. offering targeted therapeutics, offering immune therapeutics when we think they are useful. And that knowledge starts with a day one when we meet the patient. So every patient that we see that has advanced cancer, whether it's localized and cannot be surgically resected or whether it's widely spread metastatic, the first thing we assess is, do we have a lesion that we can biopsy, whether it's in the liver, in the lung, on the surface of the abdomen, peritoneal cavity. And we work very closely with our interventional radiologists to enable obtaining tumor tissue for genomic sequencing, or even RNA sequencing or other profiles that we're doing. So it's a standard of care today for all of our patients with GI cancers to do molecular profiling, and we can only do that if we have access to a tumor tissue. Indeed, we do something called liquid biopsies for patients that don't have easily available tumor tissue to obtain a blood test to look for circulating DNA from tumors in the blood. That's a little bit less reliable than a tumor biopsy. So I would say enabling biopsies fast and having access into the new building to interventional radiology that really has almost doubled the availability to obtain these biopsies is priceless for our patients.
It's going to be key. And I guess, Gabby, the question I really want to ask you as well is, we've talked a lot at Science Says and other forums at the Hutch about advances in cell therapies and advances in leukemia, advances in lymphoma. I've talked about how new immune therapies can change outcomes for melanoma patients and kidney cancer, and we have new targeted therapies for breast cancer. Yet one of the cancers that really has remained very, very refractory and difficult to treat is pancreatic cancer. And you're an expert in pancreatic cancer. What makes pancreatic cancer so hard, and what should the Hutch be doing to try to change outcomes in pancreatic cancer?
Thank you for this question, near and dear to my heart, Tom. So pancreas cancer has been thought to be one of the hardest to treat cancers, and it does have the highest mortality, in part due to being very resistant to chemotherapy, radiotherapy, and immune therapies. And in addition to that, most of patients with pancreas cancer, when they get diagnosed, they get diagnosed very late in the disease course and oftentimes have metastatic cancer. So what we really aim to do is, number one, is to research this tumor from the earliest stages to the latest stages. And with our surgical oncologists, radiologists, etc., we do a lot of research into mechanisms of resistance. And we tackle pancreas cancer now with precision medicine by knowing everything we can about the genetic mutations in this tumor, having access to new clinical trials to be directed to those genetic mutations, such as KRAS mutations. That used to be 95% of our patients. These used to be an untargetable genetic alterations, and now we have clinical trials targeting KRAS, whether we're using immune therapies targeting KRAS or small molecules targeting KRAS. We have access to all of these clinical trials and research, and our patients, I hope, will have significantly longer survivorships by having access to this research that we're doing at our center.
Terrific, Gabby. Thank you so much for all you do for our patients, both in terms of research and clinical care. And really look forward to the Q&A in just a few minutes. So we'll talk to you in just a few seconds when we bring you back. Thanks so much. So next, when we talk about bringing research and clinical care closer together, it can be daunting for patients. It can be so hard for patients. And so we're talking about supporting the kind of support patients need in terms of the financial, emotional, family stresses of cancer, and how do you navigate the system? How do you get through this incredibly challenging time? So our next two speakers, Lenora Starr and Jennifer Dees, are members of our patient navigation team, and this is what they do. And we're excited about many of the advances in care that this new building is going to enable, However, a new building can be really scary for people who don't know how to get around and how to access it and how to get to be seen there. And so I want to thank both of you for being here to talk about navigation and how we do this. And so I'm going to start with Jennifer. And so Jennifer, tell us exactly what a navigator is. What do you do every day?
We help people navigate through our lovely healthcare system, and that could be helping them with tangible needs like housing, transportation, different resources, finances, insurance, emotional support as well.
And how do patients get in touch with you? Meaning, patients, would they know to call a navigator, or how do you get the patients to start those discussions?
Ideally, the team members would identify that there's a barrier to care that needs to be that patient needs to be helped with. But we get it in all kinds of ways. We have our frontline folks that may be talking with one of the patients when they're checking in, and they'll give us a call and say, hey, this person's having some problems with transportation. It could be the nurse navigators, social workers, anybody throughout the organization that has identified a need that a patient may have, and they reach out to us and in baskets, orders, telephone calls, emails. We also get referrals by previous patients that we've helped in the past, and they're like, hey, talk to the navigators. They helped us.
Excellent. So next is a question for Lenora. So when you think about our mission statement of the Fred Hutch, we say that pursuing healthier lives for every person in every community is part of our mission statement. But what are we doing to ensure that everyone feels welcome and can access the care we provide?
Okay, one of the things that happens is I get a report from the University of Washington Analytics Department that contains registration information from patients who've been identified as their race and ethnicities have been identified on that registration. And from that report, I'll take, for example, filter out the indigenous populations is what I serve, and I will call them the patients on that list and let them know that patient navigation, these are our services that we provide, and hopefully they'll take advantage of the services we provide. We also do this for the Black African American community, as well as the Asian Pacific Islander community, Native Hawaiians, Hispanic populations as well.
And so, Lenore, one of the questions I would have for you is that I was in a meeting yesterday, and people were talking about how hard it is for people who come from far away, be it Alaska, be it rural Washington State, particularly people from Native American populations or Alaskan Native populations. What are some of the things they ask you, and what are some of the fears that people who come from further away into Seattle, what are some of the concerns they're worried about?
Transportation is a real big one. If they have Medicaid, that's a lot easier. They have travel and lodging benefits. But if they don't, we have to get other services like Angel Flight West, who is a group of volunteer pilots who offer their time and energy to help our cancer patients get to their appointments.
Terrific. So thank you. So Jennifer, can you give us an example of a patient story that struck you as being someplace where you were able to make a real difference in the care of a patient?
We have so many. I could tell you about one this morning. There's a elderly couple. The husband has cancer, and they're in the process of getting evicted from their home. And he just found out he has cancer. So we are tackling the first thing, getting him here to the appointment. Financially, they can't afford to travel here. So we're working with the American Cancer Society to get him here to the appointments. The next step is we're working with the American Justice program to give him a legal voice about his eviction. And we're working on getting him some additional housing resources putting them in touch with some other community resources.
And so what is the background that you guys bring to this? Are you social workers? What kind of background do you have train you to do a job like this, Lenora? Maybe you can answer that one. Oh, go ahead, or Jennifer, either one.
Oh, I was going to say a lot of it is our passion. We do work with the social workers. We're not master social workers. Our previous employment, other jobs that we've had, education, working with our own family members, people in the community, there's so much that went into helping us be successful, but a lot of it is just really passion about what we do and wanting to help people.
Fantastic. And so, Lenora, can you give me an example of a patient you helped recently? Obviously, without mentioning names, because we're not allowed to mention names. But if you can give us an example of somebody you helped.
One of the things as an Indigenous patient navigator, I got a referral one day from a spiritual health that a patient wanted to get in touch with us. We have Indian Shakers in our communities, and she particularly wanted prayers, and wanted to talk to a minister from the Shaker Church. And so I was able to get in touch with a friend of mine who got me in touch with the Muckleshoot Shaker Church, and so she was able to be seen by him, and he worked with her, and she was very happy about that.
Fantastic. It's a really great example, and I'm really glad that you were able to be able to do that. And I guess one question, do we have enough navigators for the number of patients that are out there? And that didn't take Jennifer long to answer that one.
Our team has definitely grown a lot in the last 2 years. Thanks for the administration and the foresight of people before us. But we could definitely use more navigators. There's such a need, and we do a lot of outreach, and we try to make sure people don't fall through the cracks. But you're only limited in the amount of time that you can spend with each patient, and some people need a lot more hand-holding to help them get through the process. And resources are, starting to dry up in some cases, but we're pretty resourceful.
Yeah, and I guess one question I would ask both of you to give me your perspective on is, one of the things that we want to make sure of, and we're trying really hard to do, is to make sure that our clinical trials that we do reflect the population of patients who've got cancer. And in many populations, there's a certain amount of distrust or a certain amount of skepticism about clinical trials. Can you tell us a little bit about how you can work with patients to understand clinical trials better and possibly understand ways that they can learn more about clinical trials?
We do have people out there, especially in prevention, working with our Native populations to try to get trust reestablished with our different medical providers. And it's a long road, but we are working on that. And there are things like focus groups that are out there, surveys that are being taken, and things like that to try to get ourselves seen out there in the public. And people like myself that work with the patients and letting them know that we have state-of-the-art equipment, and we are premier providers for cancer treatment. And so I think that helps.
Terrific. And Jennifer, any perspective on clinical trials from your perspective?
I feel that a lot of the outreach that we do in the community, we get out there, we're seeing. Fred Hutch is a great reputation. Our diverse patient navigation group, we're out there. We put our feet on the ground. We're doing events. We're representing Fred Hutch and, meeting people at different events, going to churches, community events, and word of mouth. We're out there. And we also have good trial people. They'll give us some information sometimes. We'll take that stuff out with us. And we can hand that out and speak personally about some of the experiences that we have and how we can help people build in that trust. It takes time, but I think the more that we're seeing out in the community and we care and we're making efforts to reach out to people, the better it is going to be for the future.
So Jennifer and Lenora, thank you very much. Don't go anywhere because we're now going to bring everybody else back for the discussion. If we can welcome everyone back, we're getting some terrific questions, and I would just ask people, please put questions in the Q&A, and we will be delighted to be able to ask them to our panel. So I guess the first question comes in from Stephanie Axelrod, and this is for you, Terry, and also for Jennifer and Lenora, which is, what orientation do you provide to new patients who don't necessarily need the services of a navigator or an access nurse, or how do you decide that, but they want to understand what to expect when they enter the Fred Hutch system? Cancer diagnosis can be so overwhelming, newly diagnosed patients, and they just don't know what to expect.
Well, I'll take a first stab at that. And I think it really depends on the pathway that the patient's coming in. We try to have a customized approach based on diagnosis. So a patient coming in for a consideration of a bone marrow transplant is going to have a very different orientation than, say, a patient who's coming in for a pancreas multidisciplinary appointment. And I will say this openly and upfront, we have a lot of room to grow and improve on this. We've been working on launching our nurse navigation program, which, is really that first touch, that first call to the patient, who helps us understand where the patient and family is at and what their needs are. And our goal is to make sure that every patient gets that customized, personal, warm embrace when they're coming to us for care. But I would love to hear, Jennifer and Lenora, what are your thoughts? What do you see?
A lot of times we get a referral from the staff after they start their treatment, and they'll refer for different reasons, whether it's lodging, whether it's transportation, or financial assistance. Obviously, we can't offer financial assistance if they're not an established patient here because of inducement. But otherwise, we kind of take it after we get the referrals from the providers.
We also do work with some outreach reports that are generated. I personally work with breast cancer 97% of the time, and we have meetings on Tuesdays and Fridays, and we discuss 6 patients at a time. And during those meetings, I listen for key little words that, they may live rurally, they may be on a fixed income, they may be single, or different things. And based on that, I will put in the referral and personally reach out to them. Chloe will put in the referral. We have lots of ways that we try to make sure people don't fall through the cracks, and we identify barriers to care early in the process so that we can start working on them so that the patient can just focus on getting the best care possible.
Terrific. So Gabby, one of the questions just came in, which I think is a very good one. As you know, for many of you maybe don't know or do know, right now we're writing our Cancer Center grant, recognized as a consortium cancer center. Fred Hutch, University of Washington, Seattle Children's. And this grant process will take us the better part of the next year to go through to renew our NCI designation. And one of the key things that they look at is, are we making sure that our clinical trials have enough participation from all different groups, old, young, rural, urban, men, women, Black, white, Asian, Native American, all different groups. And they look to make sure that we accomplish that. And that's so critical. One of the good examples of how the Hutch has done this, if you look at Operation Warp Speed and the trials that got vaccines approved, the Hutch played a major role in making sure that the percentage of Black and Hispanic patients was sufficient so that Black patients could feel comfortable getting a vaccine because it had been tried in big enough populations. So Gabby, as somebody working in the field of pancreas cancer, what do you do, or what can we do to try to reach out and get more patients of color, more older and younger and rural and urban patients to participate in our clinical trials?
Thank you, Tom. This is a huge interest of us. In fact, in our pancreas cancer working group with Veno Pilariseri, our lead surgical oncologist for pancreas cancer, we addressed exactly the need for us to serve the underserved population, the minorities, whether from a racial perspective or from an income perspective, financial perspective. We definitely want to make ourselves available across the state of Washington, across the 5 states that we serve. We want to actually create multidisciplinary tumor board participation such that we are in touch very closely with the community physicians. We know that in the King County, for example, versus Pierce County, Snohomish, the state of Washington, the population demographics is quite different, and we want to serve everybody in need. Of course, we treat all patients the same. When we discuss clinical trials, every patient that comes to us is being considered and offered participation in all the trials we have. The big question is, how do we attract more patients? How do we attract those who are underserved? And I feel that it's our duty to make ourselves available to the community and to educate our community doctors about the research we're doing such that we can serve the patients in need. So I think it's our duty to, as I said, make ourselves available, to spread the knowledge, to spread the inclusion into clinical trials, also to have our research trials available through our network, such that more and more patients outside of the South Lake Union region have access to them. And we're working very hard to accomplish that, Tom.
Terrific, Gabby. Thank you. So Delphine, a question has come in for you. And it's, will the new imaging machines be suitable for patients with surgically implanted hardware, or will the UW continue to be the resource for that type of imaging?
Yeah, so depending on the implanted hardware, all of our scanners can accommodate the breadth of surgically implanted hardware, cardiac pacers, metallic implants in bones. And so we will be able to do that. I think as the oncologists decide where they want to send their patients, or even where patients want to go, we will be able to accommodate that. And just, the PETMR will be available for patients outside the Fred Hutch as well. Radiology does take referrals from external providers, so these imaging facilities are open for patients from anywhere that wants to be seen at Fred Hutch. Just as Gabby said, we want to be available and accessible for all patients who have a need. And so that similarly applies to radiology and our imaging capabilities.
And Delphine, can you think, please, I don't know the answer to this question, but can you think of non-cancer uses of a PET MR?
Oh yeah, so brain is one of the very first applications for PET MR. Neurodegenerative disease, Alzheimer's is a big area. And yeah, and cardiac is another big area, looking at fibrosis or like ischemia or cardiomyopathy. And these things affect our cancer patients. So just because you have cancer, unfortunately, it does not mean that you won't be touched or affected by these others. And so PETMR has some clear advantages in those areas also.
Great, thank you. And Gabby, as a GI oncologist, in addition to pancreas, you also work on colorectal cancers as well. And will anything in the new building be able to enable additional screening? And how do we think about screening, particularly now with the understanding in colorectal cancer that we probably need to be starting to screen people younger in age, given the it seems like an epidemic of colorectal cancer in young people?
Absolutely. So the new building actually enables more space for gastroenterologists as well as for our surgeons to perform screening endoscopic procedures. And we know that, of course, colorectal cancer affects many of the 20 to 40-year-olds. In fact, it's the largest increase. And we are actually working very closely to even discuss screening blood tests that could actually catch cancers before they show any symptoms or signs. So we actually have a team of geneticists as well as GI physicians and oncologists all working towards enabling these new screening tools to catch the cancer before it shows its symptoms. We are very, very passionate about that, as well as educating the population and primary care physicians to really recognize early signs of colorectal cancers and not dismiss them. So I think patient education, early tools for blood screening as well as endoscopic screenings will be fostered in this new space and having more space available.
So, Gabby, thank you. I'm going to give the last question to Terry McDonald. I could ask questions for you guys all afternoon. These have been really fantastic. So, Terry, one of the big things we're struggling with is workforce, and how do we recruit, particularly nurses, to the Fred Hutch? And I've got to believe that the new building is going to help in that area. Tell us a little bit about your efforts at recruiting and how that's going, and are you able to staff up and get enough people to be able to work in the new building, whether it's as a nurse or as a radiology technician or clinical trial staff? What are how do you think about staffing of our new building?
Well, we've been thinking about it for a long time, and we've kind of come at it from a three-pronged approach. One is training, so we've stood up a lot of new training programs: pharmacy tech, imaging tech, nursing tech, nurse residency, new to specialty programs. So those are our pipeline programs. But then we've also been working very closely with HR and recruitment on really getting the word out there. We had an event on a Saturday where we actually did a recruiting event on the 7th floor of Building 1, so that people from the outside who were thinking about coming to the Fred Hutch got to see what the environment was like. We got an overwhelming response from that. And the other is really ensuring that we engage our current staff. There are nurses and techs who don't necessarily want to be in the same specialty or the same role for the entirety of their career. So we work with our managers and our education staff to give existing staff opportunities in other areas of the organization. And that's helped us retain a lot of our staff. So we're working hard at it every day. And fortunately, we have enough staff to open the building safely.
Terry, thank you. Jennifer, Lenora, thank you. Gabby, thank you. Delphine, thank you. And thanks to all the participants. If you're interested in learning more about the work you heard about today, visit us at fredhutch.org and follow us on social media at Fred Hutch to learn more. One key thing, folks, is folks like you fuel the research and the care for our patients. Please consider making a gift today at fredhutch.org/give to support the program of your area or area of cancer research that's most important to you. And all gifts made by March 31st, which is Friday, will be matched up to $350,000 thanks to a very generous matching gift from the Krabby Beach Foundation. I want to close by reminding everyone of registration for Obliteride, which will happen the registration starts later this week and next week, April 1st. And Obliteride itself is on August 12th. And I really hope to see everyone on this call at Obliteride this year, whether you want to volunteer, whether you want to ride, whether you want to walk. We have lots of opportunities for participation of people who work at the Hutch and people who are friends of the Hutch. Thank you all very much. Look forward to joining you for our next Science Says in May.